Welcome, everybody. Please help yourself to the food and the water, sparkling water that's in the middle. So my name is Victoria No. I'm the Deputy Director of the Center for Innovation in Mental Health here at CUNY School of Public Health. And we are really excited to be able to be here with Dr. Enola Proctor and launch our grand rounds for the year or for the semester. Dr. Enola Proctor, as many of you know, is the leading implementation science researcher. She's the Shanti Kanduka Distinguished Professor and Professor Emeritus at the George Warren Brown School at Washington University in St. Louis. And I know her as the mother of implementation science. I've been fortunate enough to have been mentored by her through the Implementation Research Institute, which is funded by NIH, and that's one of many implementation science research networks that she runs. She also runs the Dissemination and Implementation Research Core for Washington University at the Institute for Clinical and Translational Science, and the Center for Dissemination and Implementation at the Washington University Institute for Public Health. She's probably best known for her groundbreaking scholarship and leadership in building the field of implementation science, particularly how it applies to mental health services. She's a pioneer leading the field in her work in clarifying implementation models, identifying strategies, and linking them to outcomes. For nearly 3 decades, she's also led the Brown School Center for Mental Health Services Research. The center collaborates with the national network of research partners to build a base of evidence designed to address the challenges of delivering mental health services to vulnerable population. Dr. Enola was also appointed by the U.S. Department of Health and Human Services to serve as the National Advisory Mental Health Council of the National Institute of Mental Health. And she's the only social worker to have been awarded this prestigious appointment. She's also served as a strategic planning expert to the NIH Offices of Behavioral Social Science Research and serves in the Institute of Medicine's Committee on Developing Evidence-Based Standards for Psychosocial Interventions for Mental Disorders. Dr. Proctor has been recognized in numerous awards, including the Lifetime Achievement Award for Society for Social Work and Research, the Presidential Award for Excellence in Research, the Nee Whitman Award for Lifetime Achievement in Health and Mental Health Services, or Mental Health Practice, and from the National Association of Social Workers. She's a member of the inaugural class of American Academy for Social Work and for Social Welfare. So throughout her career, Dr. Enola Proctor has been committed to the implementation of evidence-based practices and the translation of research into practice. Her research, teaching, and policy development activities has improved the quality of mental health services available to vulnerable population. And I just learned that in her free time, she also volunteers and goes out and gets the vote out in St. Louis and calls her congressman every morning, every day, to fight for social justice. So she's an inspiration to all of us and to many of us who've been a little bit of time. So please welcome Dr. Enola Proctor.
Thank you, Vicki. That was a lovely invitation, and I only make that call every morning during peak activity times. And I just took a restroom break and thought, should I call? And I thought, no, they're probably voting, so I didn't call today. But we all try to do our part however we can. So I'm so pleased to be here today. So thrilled to see Dr. No in her new quarters and meet her colleagues and the exciting work that's here, that's the infrastructure that you're building, the important science that you're conducting, and it's just been a real treat. So thank you so much for the invitation and for the lovely introduction. So clicker or keyboard to advance the slides? Clicker seems to... There, okay. So the keyboard, both work? Okay, all right, okay. So a few disclosures. As Vicki said, I have recently moved to emeritus status, and it's the best of all worlds because I work 50% or 3 days a week, and it's only having those extra days that lets me be on the phone so much for social justice. I'm sure my senators are sorry I retired. So as Vicki said, my work has long been focused on the question of how adequate is our mental health care in the United States. And I've loved having a career that has spanned some of the major historic events and efforts to improve our system of care. Jimmy Carter's work really launched the field of epidemiology and services research because when he was campaigning for governor, his wife was bombarded with the question, what is he going to do to improve mental health care? Consequently, when he became president, he says to sort of get her off his back, he asked the question, how good is our nation's mental health care? How adequate is this care? And we didn't have ready answers. And that's what really launched the NIMH's service system research portfolio, which in its heyday was just an exciting source of guidance and, most important, research funding that helped fuel my career. So over the past 30 years, we've seen many routes to trying to improve mental health care. We've focused on improving access. We've focused on system coordination. We've focused on co-locating mental health services. And most recently, we've focused on implementing evidence-based interventions. And if we would look at those four bullets kind of reflect many of the themes in my successive research projects. Certainly, we became aware through epi and clinical epi research that people with mental health needs are everywhere. And I know New York City knows that, and you're making a concerted effort to expand the reach of mental health services. We've learned that primary care, many patients come with physical complaints, but the underlying issue and the key to improving their situation is addressing their mental health needs. Our center did a lot of comparable research on another sector that we viewed as another sort of primary care, and that's our social services network. We did research in child welfare, in publicly supported services for older adults, the criminal justice sector, even the voluntary not-for-profit sector that Daryl Rigor identified in the de facto, his article on the de facto mental health center. Some look at recreational activities for kids. And we learned that up to half of people approaching non-mental health settings and non-mental health providers had unidentified or untreated mental health needs. So, how did we respond to that? Well, we've tried a number of system integration innovations over time, trying to break down the silos. Right now, even today, too little primary care is well integrated with mental health and substance abuse care. We know that medical care is siloed, organ-focused, disease-focused care dominates our provision of medical care. And for mental health, this leaves us in a really bad position because the latest data show that over half of people with mental health needs get no care. And there are many reasons for that. Some people can't afford it. Some people say they can't work it in because mental health care is too far away, is too expensive, hours are not accessible. We don't have urgent care for mental health. And we see what's happening with urgent care. Everybody's going to get medical care after hours and on weekends. Often people don't know where to go for mental health care. And then, of course, we have stigma, or we have a number of beliefs that people should be able to handle these very serious problems on their own. We've also learned that opening up the gates to access is not sufficient if we aren't also addressing how we can improve quality. And are provided, only a fraction of people get evidence-based care or get interventions that have proven effectiveness and efficacy. And the Institute of Medicine, now called the National Academies, has issued a series of really significant and impactful reports contrasting the care that most of us get with the care that we could get if we were receiving evidence-based or the highest quality of care. To Err is Human called our attention to medical error. Crossing the Quality Chasm challenged us to move evidence-based care into routine care. The third book there focused on substance abuse and mental health, and the most recent book was on how we ensure that psychosocial interventions that are evidence-based are more widely delivered. So the last portion of my career and what I want to talk today about are really the challenges in implementing evidence-based care in real-world settings. And while many of my examples come from mental health, my work has, over the past 15 years, expanded way beyond mental health to look at all aspects of healthcare, including inpatient care, intensive care settings, community-based care, and public health. So the National Institutes of Health have called our attention to this problem of accelerating the delivery of evidence-based care. and they've now issued 5 or 6 iterations of a call for proposals, Dissemination and Implementation Research in Health. And this is the most recent program announcement issued just last year. And of great importance is the fact that this is a cross-institute initiative. So the challenges of delivering evidence-based care are recognized not just by the National Institute of Mental Health, which I referenced in the first part of my talk, but 18 different institutes have signed on and invite grant submissions with the stated purpose of improving the dissemination and implementation of evidence-based care. So NHLBI, NIDDK, most recently NIA, oral health, infectious disease. This is recognized as a health-wide and therefore a National Institute of Health-wide priority. And that program announcement tells us that, the purpose of dissemination and implementation research in health is really to support innovative approaches to identifying, first of all, understanding and developing strategies for overcoming the barriers. So implementation strategies are a really key emphasis in this research portfolio. And why do we need strategies? We need implementation strategies that can help achieve the adoption, the adaptation, the integration, the scale-up, and the sustainability of evidence-based interventions, tools, policies, and guidelines. So we have in this program announcement also, let me go back to that slide. We have the how, we have the what, and we have the outcomes, all indicated in this one slide. So, this is kind of a primer to what the NIH is addressing. Very few studies address all parts of that, but they're really inviting rigorous research that can advance our understanding of strategies to achieve these key outcomes of evidence-based tools, policies, and guidelines. We know, however, that starting up new services is not the only goal, because all the data about current quality, if only 3% of people receiving mental health care are receiving evidence-based interventions, what else does that imply? It implies a need to stop delivering services that are low-value care. And low-value interventions are those that are ineffective, are unproven, or even harmful. And those of you who work in infectious disease are certainly seeing an example of de-implementation or de-adoption research with antimicrobial stewardship. We know that by administering so many antibiotics, we've actually harmed our public health, and we have harmed some individuals. So I think it's a lot easier for people to get excited about learning something new than it is to learn how to stop doing what they've been doing because they were trained to do it, because they believe it works, and they believe it will be helpful. So this is really an important frontier. How do we rein in some interventions? And yet, if we're researchers, scientists, surely we all believe that 5 years from now, we're going to know some things that put out of date what we know today. That's why that's why we're all in science, right? And if we're optimists, we surely believe that healthcare is going to be better in a short period of time than it is now. People who are struggling with disease for which cure rates are low are very hopeful, and they're waiting for new discoveries. So it should be easier than it is to comprehend the value of stopping, reducing, or de-implementing care that is ineffective, unproven, low value, or harmful. And yet, this is not proving easy. We know that consumer demand, and I've been among them, I haven't wanted to continue coughing for 6 weeks. And I said, give me an antibiotic. And the evidence is you don't need one. And I think, we all have work, we have lives to lead, we want a quick fix. So we're part of the problem as we demand interventions that we think work, but really there's no evidence to suggest that they do. And similarly, it's a very tough thing for providers. So this is the newest addition to the newest program announcement for dissemination and implementation research in health. And really reining in some interventions and reducing the delivery of non-evidence-based intervention is a very innovative space in the present and near future of implementation science. Now, you may notice that the program announcement is called Dissemination and Implementation Research in Health. And if we were in Canada, we would be talking about knowledge translation, and we would have one term for incorporating all of this. But the National Institutes of Health have distinguished dissemination research and implementation research, I think for good reason. They've identified dissemination research as really focusing on information or evidence, where implementation research focuses on practice change. And if we were to look at the portfolio of funded work in this area, we would see that we have too little dissemination research. And certainly, ultimately, we want to change, we want to improve practice, but we have enormous problems. Sometimes I worry that we have growing problems around the acceptance of evidence. We see this widely in vaccine pushback. We see this in a number of areas where evidence is not persuasive. And so the NIH really invites research on how do we get scientific evidence disseminated to public health or clinical practice audiences and get it accepted, get it respected, because it's rarely actionable to change practice if that information in and of itself is not persuasive and is not accepted. So those are some complicated definitions of implementation research. I have loved a definition that I heard Carolyn Clancy, who was then director of AHRQ. She's now working in the VA. Do we have some Carolyn Clancy fans in the audience? And in a talk, I don't know if she knows that I've quoted her ever since, but she said, implementation science is just really about making the right thing to do the easy thing to do. And this is what we all want. We go into helping professions because we want to do the right thing. But unfortunately, we're finding it's not easy. Implementation science, this is a slide courtesy of David Chambers, who's now at the National Institutes of Health. And I think it helps us position implementation science in what he calls the big tent of related areas of inquiry. And you'll see that the biggest circle is health services research. And I really went to school to prepare for, I think, my work in implementation science through health services research. Social work is really all about service delivery. And I learned a lot of methodological skills and conceptual frameworks for my research in the social services arena from health services research, although I have no degree, have no formal training in health services research. But I am an Academy Health junkie. How many have been to Academy Health? Okay, it's a tremendous conference with really rich, rigorous workshops on methodology, They focus on practice variation, indicators and electronic records of procedures. So a lot of the methodologies, how to measure procedures, a lot of the methodological tools that we need in implementation science have their root in services research. So again, this slide shows the distinction and the relationship. You'll see some overlap there between dissemination research and implementation research. It also highlights how much we need to draw on health communication research for dissemination research, and how much we need to draw on quality improvement science for implementation research, and shows that a lot of quality improvement initiatives, as they're intended, are really not research. They're just efforts to improve things. They're very important, but it's often does not benefit from research methods and does not contribute them back. Implementation research, if we think phases of discovery, addresses some different questions. This oldie but goodie slide, now almost 11 years old, shows three questions. What do we target? What do we deliver? And how do we deliver? And certainly what to target, epidemiology, clinical research, pre-intervention research helps us figure out what are the most pressing problems to address. And then what do we deliver? That's where we're developing interventions in efficacy and effectiveness research. But knowing what to deliver seems insufficient for changing practice. So how to deliver is really the focus of dissemination and implementation research. So all of these questions are important, and without research on what to target and what to deliver, we have no material for implementation research. So one is not better than the other. They simply address different questions in our attempts to improve healthcare. So if Carolyn Clancy says implementation research informs how to make the right thing to do the easy thing to do, why is it not easy? And why, if we have a flourishing body of research about what to deliver, why do we still have such a wide chasm between the care that is and the care that could be, or the care that is evidence-based? Well, a lot gets in the way. And I would characterize the first phase of implementation research over the past decade and a half really expanding our awareness of the barriers. Barrier assessment was viewed as kind of the starting point for our field of implementation research. And certainly we learned that a lot of attitudes, a lot of structural problems, a lot of knowledge, a lot of skills get in the way. But we have needed to move beyond the identification of barriers and facilitators to guide our science. So this slide, many of you have seen versions of it. I'm going to walk you through it, but it really shows the usual type of effectiveness research as testing a what, and in implementation research, we do need a what. Remember, what do we deliver? And our ultimate goal is improving patient outcomes. So that's the usual paradigm in effectiveness and efficacy research. But in implementation research, we crowd this picture by adding some additional factors. As that previous slide showed, in addition to knowing what to deliver, we need to learn how to deliver those interventions, and those are called implementation strategies. We also need some additional outcomes, and implementation outcomes include such things as, is this intervention feasible for this setting of care? Is this intervention delivered with fidelity? Does it penetrate the system of care, or are only the 1% of the easiest patients getting the evidence-based care? Are these interventions acceptable? Can they be sustained? And is there widespread uptake? And is cost feasible? Can we get around the cost barriers? So unless we achieve the implementation outcomes, we stand a much lower chance of actually seeing the benefits of those evidence-based interventions. All of this is delivered in context, which is critical set of variables in implementation research, and these factors are really the core of implementation science. So you saw that in addition to clinical outcomes, there are distinct outcomes that need to be measured in implementation research. And why is that? Well, without testing those implementation outcomes, we could have a very effective intervention that we're testing only in relation to clinical outcomes. But our evaluation or our research might miss the fact that those were really never adopted. Someone got training, an agency or provider intends, wants, wishes, tries to deliver the intervention, but it really may not be delivered, especially it may not saturate the healthcare system. Or it may be implemented but with poor fidelity, which is something intervention developers worry about a lot. Or people start delivering it but they don't sustain it. And then if we focus only on clinical outcomes and we don't see the results that we hoped for, people are not getting better, we might actually conclude that the intervention didn't work, and we could throw out the intervention without that evidence. So assessing implementation outcomes is really important to guard against that error in judgment. Implementation strategies, or the how, are really the methods or techniques that are used to try to achieve those implementation outcomes, or as we've said, the how-to of implementation outcomes. And I was sharing with the students yesterday that I think my career has been shaped by questions that the field lobbed at me. And I remember a day in which our school had introduced an evidence-based curriculum for MSW education, Master of Social Work. And we had been communicating this to the agencies where our students were placed. And one very thoughtful executive director came and said, okay, Enola Proctor, I get it. My organization is delivering over 20 programs. And I've done some literature searching, and I could only find a few of them in the literature. And fewer of them are evidence-based. And I want to decrease that number of 20 to those that are evidence-based. I want to get rid of the ineffective care, and I want to increase our delivery of evidence-based practices. So you talk about evidence-based practice. What's the evidence-based practice for me, an agency director, an organizational CEO? What's the evidence-based approach for me to bring more effective practices into my agency? And prior to that conversation, I'd not really named or done work on the concept of implementation strategies. But that question really launched me and my team to say, what is the how? You know, we've been preaching about evidence-based practices. So that question was really formative and influential. And for the past 20 years now, I've been doing research on how do we think about the key ingredients in implementation science and trying to unravel these components. So a group of us set out to establish for ourselves, and then we decided to share it with the field, a list of implementation strategies, and we've done a couple of refinements of that. The most recent one is reflected in the ERIC, or the Expert Recommendations for Implementation Change project, where we really ask the question, what strategies are people using And while the first compilation we published, which is called a compilation of implementation strategies, was based on published research, this is really based on practice. We took that original compilation and we vetted it we had practitioners, implementation experts, many of whom were in the VA and were part of strategic rollouts or strategic implementation efforts. And we said, how are you doing this? What strategies are you using? So that's where the expert recommendations comes into the title. And we use concept mapping. We've done several studies subsequently, but this is where did that go? Did you see that? Did that spin? Okay, it did here. Excuse me. So we came up with these categories of strategies. There's a lot of training and educating stakeholders. There's a lot of supporting clinicians and concept mapping groups, similar kinds of constructs together. So this is kind of what we do with clinicians. We also have learned that changing the infrastructure and ensuring that things can be paid for, dealing with the financial costs for delivering strategies is important. We also learned that developing stakeholder interrelationships is important and addressing contextual barriers. So we know that systems are linked and that systems of care form partnerships this is very involved in task shifting and co-locating. And then obviously engaging consumers of our services. So this is kind of was the first concept mapping depiction of implementation strategies. So I've been making the distinction between the what and the how. The what is the evidence-based interventions and the how are the implementation strategies. And I want to show you a couple of slides that I drew from actual NIH reporter searches. So I did some searching of, and if you haven't done a reporter search, it's a terrific exercise. It's a searchable website. Every funded grant paid by the NIH is listed in this NIH reporter. And you can search on disease topic, you can search on funding agency, you can focus on study section that reviewed the application. And these slides came from a search looking for applications that had been reviewed and were subsequently funded by the Dissemination and Implementation Research in Health study section. So I was looking, and all you get are the abstracts. You get the project title, the PI, their institution, and the abstract. You don't get the grant narrative. You have to use a Freedom of Information request or contact the PI. But from the abstracts, we were able to see that many grants that are D&I do distinguish between the evidence-based intervention and the implementation strategies. For instance, a grant on implementing collaborative care models in community health clinics was using value-based purchasing. That was that triangle up at the top of the financial strategies. A project implementing depression treatment in home health agencies was using strategies targeted more to the clinician. They were doing training, they were providing supervision and consultation, and audit and feedback. And then we see a substance abuse grant that used both clinician training and payment changes. Other strategies that we see in NIH grants are mobile technology, computers, decision support champions, audit and feedback, and then train the trainer models of training. So this is further indication that the Dissemination and Implementation Research in Health Study section is interested not just in the what, the evidence-based practice, but also science on the how, or science testing the implementation strategies. So implementation strategies add to the complexity of our research. First of all, it's a second intervention that we have to deal with. We have to deal with the evidence-based intervention, or the what, and then we have to deal with the implementation strategy, which is another kind of intervention. And it's like, you know, the old Sesame Street song, one of these things is not like the other. Some implementation strategies we've characterized as very discrete. You know, it may be a reminder. It may be a checklist. We can see it. It's pretty concrete. But others are very complex. And PCORI is giving more attention in their methodological core to how do we study complex interventions. And certainly implementation strategies comprise complex interventions. And some of these are combinations, such as training and technical assistance, or big bucket kinds of strategies like practice facilitation. And then we're seeing a few initiatives where researchers are kind of protocolizing and bundling very complex interventions. I've worked with Charles Glisson on the ARC, A-R-C, organizational intervention, which is basically a 2 to 3 year intervention in an organization to change many parts of their culture, their operating procedures, et cetera. It's really quite complicated. So given the variation in implementation strategies, how do we study them? Well, in terms of research designs, we need comparative effectiveness research. We need not just to know that a strategy was used, we need to know, was the strategy effective, and we need to know, was a strategy more effective than another particular strategy. We also need to know their cost. There's a phone call coming in somewhere here, but I'm not going to answer it. Yeah. Okay? So just letting you know, you have an incoming audio call. Yeah. Okay. Maybe.
We have the capacity for people participating.
Okay. Should I answer it? No. It might be my senator explaining their vote.
Don't encourage them.
Okay. So, and most of all, we need we need research that tells us what strategies work in what context, in what empirically supported treatments. And I think we need more parsimonious strategies for reasons that I'm going to show soon. And then what implementation strategies are most effective for what implementation outcomes. If acceptability of an intervention, you know, people just aren't saying, nope, I can't go there. What strategies are useful for that? Or if the implementation outcome we need to be working on is, yeah, people buy it, but it's not reaching as many people. What strategies do we need for that? Do we need a unique set of strategies for sustainment, for scale up? So, you know, we don't know the answers to this. So I'm bombarding you with lots of areas for innovative research. The field is wide open around many of these issues. Now, I've done a couple of studies where I have learned just how many strategies are used in real-world implementation. In the field of mental health, there is a phenomenon that we've called intermediary or purveyor organizations, and these are really rollout shops. They vary, but their purpose is to disseminate information about evidence-based interventions and to provide technical assistance to adopters. Many of these shops, and we learned that over 90% of behavioral health interventions have an associated purveyor organization associated with it. So it's really big business, but we really don't know they've not been studied much. And we wondered, what strategies are they using to help adopters take up these evidence-based interventions? And so we did some survey research, and we learned, asking people, which of the implementation strategies are you using? And we learned that the mean was 32 different implementation strategies. In other words, one agency, in order to disseminate an evidence-based intervention, was employing 32 different strategies. And to focus more specifically on one, albeit national, rollout, our team studied the implementation of hepatitis C treatment in VA clinics. And the VA had endorsed this as a high priority practice improvement, and they even provided resources to sites. So this was a national initiative with resources, very specific aims. And so we studied the VA sites that had taken this challenge up under the leadership of Sherry Rogel, who's a IRI network. And here again, we found that sites reported using 25 plus or minus 14 different implementation strategies. And the range was between 1 and 51. Now, here we look to see the outcome in terms of new treatment starts. Did these strategies work to really mobilize the initiation of new hepatitis C treatment? And we found that, so we segmented the sites, and the most successful, the highest sites with new treatment starts had used 33 strategies. And the lowest quartile, the group of agencies or sites that had the lowest adoption or new treatment starts for hepatitis had only used 15 strategies. However, it's not a totally clear picture, because just because they identified a lot of strategies didn't mean that, every one of those had successful treatment, or the strategies that were frequently endorsed. And only 3 of the 15 most frequently endorsed strategies were associated with new treatment starts. So we're finding that, and I said that I think we need to have more parsimonious implementation strategies. If I'm partnering with an agency and to say, to implement this intervention, you have to do 32 different things. And that's a little overwhelming. And yet, we do have evidence accruing across a lot of studies that the more strategies, the more effective. What does this tell us? First of all, the implementation is complicated. And my colleague Joanne Kirchner says, yeah, we have to use that many strategies. So we'll see how we develop in this field. There again is a question for you. One of the challenges around implementation strategies is that just like interventions, we can't just tell people, oh, this is what training looks like. I think implementation strategies carry the same requirements as interventions, in that we need operational definitions, protocols, manuals, and we need to test their fidelity. But our language about implementation strategies has been very murky, and most implementation research studies reporting strategies leave out a lot of detail. So our group felt that we can't really grow this science unless we have better reporting on implementation strategies. And we have challenged authors of papers around implementation strategies to tell us who used it. Was this action by the CEO? Was this action by the frontline provider? Was this action by the funder? We have a lot of actors in implementation. A lot of people are working to do this. So who did what? And please use names that we can terminology that is common in the field. What did they target? Were they targeting the policy environment? Were they targeting the organization? Was this a patient-facing strategy? Was it a provider-facing, to whom was this strategy directed? And how much? Was it a 1-hour training? Was it a 3-month certification program? What was the dose? And if there were multiple parts, was there a sequencing? And what were they trying to achieve? Were they working on acceptability, fidelity, penetration? And where did they get this strategy? Did they come at it from some theory, or did they have some research that it worked? So this is largely lacking. But I think if we had this detail, and everybody who does a study, we have this, we could report it. So it's simply a reporting challenge so that the rest of us can benefit from what you know and what you did. So how am I doing on time? There's no clock up here. Okay, we'll move on then. So how do we select strategies? Well, obviously we should be doing it strategically to address the barriers and for particular implementation challenges or phases, such as, are we just introducing something, or are we trying to scale up or sustain? And then we should really consider the context. What is the setting infrastructure? Does this setting have the data monitoring? Does it have the training? Does it have the equipment? Does it have the location? Requirements for this evidence-based intervention? Or do strategies need to address that? And then I'm a big believer in building on people's prior success. I've been doing for the past 3 years some work in Rwanda around implementing more evidence-based hypertension care, because hypertension is not high on the radar of most health systems, nor is there much public awareness of hypertension as a problem until people die of stroke. And yet Rwanda has done a pretty remarkable job at HIV surveillance and control. They've made marked improvements. So through this NHLBI project, we've been, and our purpose is to equip the Rwandan researchers to write grants. It's not our grant. We're doing training and capacity development. But this last year, we decided to focus on tapping their understanding of what has worked well in their system. How did they manage progress in areas where they have improved? And then once they could identify some of those, we vetted those and said, are those still feasible? And do you think they would work with hypertension care? So, I don't believe that implementation researchers airdrop in, to a new scene where people have not implemented and we have the answers. That's a setup for failure. I think it's really important to know the context, to be very grounded in the service system, and to learn what they've been doing, what their goals are, and what has worked for them. So there's much guidance emerging around the link between strategies and barriers. Not all strategies are equally positioned to address all barriers. But nonetheless, we do have remaining challenges. Certainly the language, the terminology confusion, the lack of specification. A big problem is data on strategies. I know of no procedure codes for implementation strategies. Do our health system records ever indicate at an individual delivery of healthcare level that audit and feedback was in place, or that the provider delivering this care had received training? No. So we have this paucity of data that doesn't reflect, we don't even have a coding system. And therefore, how do we get data about what strategies are used? Well, we rely on self-report. And therefore, we use open-ended methods when we say, tell me how you brought this terrific change about, or what has worked with you before. Or we use a structured taxonomy, a checklist, and that's how we've used our ERIC strategies for that. But there are some emerging approaches, such as observation. There's a fairly recent report on ethnography for implementation research. So how can we use observation to capture the strategies that are used? And although there are no procedure codes, there are meeting notes. You know, there can be clinical team meeting notes. There could be board meeting notes that, you know, we're going after this new funding. Policy strategies were in place. So some archival records could be useful. But another challenge is perspective because of the multiple actors. My very first effort to pilot the ERIC compilation, that is, you know, we had a list of 70 strategies and we said, did you do this? Did you do this? Did you do this? And I was studying one system of care. And for some reason, I thought it would be good to get the perspective of multiple stakeholders. So I had multiple frontline providers, I had multiple clinical supervisors, I had directors. And I asked them, did you do this? Did you do this? Did you do this? And we looked at the data, and you know, my research assistant came back and said, this method doesn't work. This is a mess because there's no commonality in what people are reporting. And I thought, okay, you know, that could be this list we made makes no sense. It can't be used. But then we began to look at the data, and we found that the providers were all endorsing similar strategies. But those were different strategies than were endorsed by the clinical supervisors. And those were different strategies that were endorsed by the agency leaders. So, you know, it's sort of like the elephant. You know, when we have multiple actors, different people are pulling different levers or using different strategies. So I think we have to use caution when we go interview people about what strategies did you use, because they're going to be telling it from their own perspective, and we need to realize that there are multiple actors in any implementation issue. So, or that slide repeated, sorry about that. So I wanted to close by talking some about the complexity of implementation science and how we bring rigor to it. So certainly strategies are complex, and this is a paper led by another colleague of ours, Alicia Bunger, who took learning collaboratives and unpacked it. And she found that, you know, there were actually 11 different strategies there, highlighting the complexity of implementation strategies. And I'm sorry, these are coming up in a little different order than I expected. Okay, we'll get to it. I'll come back to complexity. So research designs are the way that we add the rigor. And control is how we, measurement and control is how we get rigor, right? And that's easy when we're excluding a lot of variables. But in implementation science, when we're bringing in the context, the strategies, the evidence-based practice, the setting, the provider, you know, then we have to use some innovative methods. And some of the main design innovations that have come along are, in addition to randomized control trials, certainly a lot of pragmatic trials and quasi-experiments, stepped wedge and sequenced rollouts, case study, and certainly ethnographic. Many of you, I'm sure, are familiar with the notion of hybrid designs, where we've tried to capitalize on the strengths of effectiveness research and implementation research. So hybrid designs were specifically developed to bridge the gap between those two types of research studies. And hybrid designs, there are really three types. In type 1, you're really focused on testing or validating the clinical intervention or the prevention program. And while you're doing that, you gather a little bit of information on implementation processes. Hybrid 2 designs kind of equally balance these. But hybrid 3 is where you're really testing an implementation strategy, but you want to be sure that you monitor the clinical outcomes to ensure that when it is implemented through this strategy, we're still getting the positive effects that we expect. So the primacy on different kinds of outcomes will vary by the type of design. And in a hybrid 1, the priority will be on clinical outcomes, with implementation outcomes playing a secondary role. In a hybrid 2, there's sort of an equal focus. And in hybrid 3, it's the primary emphasis is on the implementation outcomes, and the clinical outcomes are secondary. So as you're writing aims for a hybrid study, this kind of emphasis may help ensure reviewers that you've got the emphasis in the right place. Okay, so now the challenges. Certainly the complexity, the multiple levels of context that we've talked about, and accordingly, the multiple actors. We address context instead of ruling it out. We have multiple types of outcomes that we need to measure and understand the relationships between. We have 2 interventions, the what and the how intervention, the evidence-based intervention and the implementation strategy, which by definition is complex. And we are studying a change process, which is rarely linear and rarely fits the typical analytic and measurement designs. So how do we bring rigor to that? Well, as I said, design and measurement. And we need to, with greater finesse, distinguish the variables in all of this complexity that we're measuring. Contextual factors, we need to measure organizational leadership. We need to measure the climate and culture, the readiness for change, the infrastructure that's in place. We need to measure implementation outcomes, and we need to measure service system and clinical outcomes. I'm primarily at this stage in my career concerned about the impact that implementation science can have. And I think it's time for us, while we continue to build and make our science more rigorous, we need to be moving to questions beyond implementation outcomes. I think we need to demonstrate that our implementation strategies have real-world effects, such as really increasing provider receptivity and use of evidence-based interventions. We need to demonstrate that we can broaden the reach of evidence-based practices, such as, the VA has, through their national effort, implemented over 50 new effective practices. We need to show that we do have a little bit of evidence that successful implementation actually boosts the clinical effect size of the intervention. Charles Glisson's research has shown this. In other words, interventions that are developed with an evidence-based strategy have a higher effect size than interventions that are not delivered with effective implementation strategies. We need to tackle such issues as, can we reduce staff turnover? Can we really achieve service system improvements? Can we speed up the time? I, for one, am tired of saying the implementation of new discoveries in routine care takes 17 years. I really don't know how long it takes. But we need to figure that out. And we need to figure it out whether moving faster is a good thing or if it has negative effects, and how we might speed up the process. And finally, we need to be looking at issues such as equity and population health outcomes. So again, implementation science has had a tremendous period of flourishing. Our methodology has advanced. Its acceptance and conduct has increased. but it's really time, I think, for us to ensure that we're testing and can demonstrate effects on public health. So I'm going to close with a few resources. How many of you have been to the annual conference on this to advance the science of D&I in health? It's just down the street in Washington, D.C., says a Midwesterner. I know it's not just down the street for you, but it's pretty close. It's a terrific conference that is cross-NIH, and in sessions you will learn about specific topics from a variety of disease and institute perspectives. There are also training programs. We have a number of alums in the area, Geeta, Victoria. We have other alums in the area who graduated from the Implementation Research Institute. And I wanted to plug 2 new trainings that are currently receiving applications. This is a training in system science for social impact. And this little post-it over here says, to build a professional network of system thinking scientists at various levels. And given the nonlinearity of change, system science tools are really critical in implementation research. So this summer at Washington University in St. Louis for 5 days, Doug Luke and his team will be leading a summer institute in system science methods. And then for the first time, just recently funded, in fact, I'm not sure they have the notice of award, but the program told them to go ahead and start recruiting. There's a new Institute for Implementation Science Scholars. And both of these are very, very similar to the IRI. This one actually built on the IRI approach. But this is focused on research to eliminate chronic disease disparities from an implementation science perspective. So OBSSR is the funder, with NIDDK being the primary, or OBSSR is overseeing it, NIDDK is paying for it. Applications just open. So I've given you 2 slides with the web links, and you can, if you didn't take a picture, Vicki has these slides and can help you with that. There are a growing number of books. There are some new journals. Implementation Science is my go-to for my self-study. It has an online, it's free, open access, a searchable database where you can find at your fingertips every article that's ever been published. They have a brand new journal called Implementation Science Communications, and this website talks about the distinction in the types of manuscripts. And then there's a new, brand new, hasn't been published yet, but they're accepting manuscripts for review, Implementation Research and Practice, that the Society for Implementation Research Collaboration, or CIRC, has launched. So 2 new journals for outlets. So thank you for a terrific day, for your attention here, and I think we've saved a little bit of time for questions before I catch my plane. And for those of you that are, in addition to getting a phone call notice, my phone went crazy and told me that the impeachment proceedings are over. So
if you're joining us on Facebook, please chat in. We are looking at the chat.
Happy to entertain questions or join you around the cookies, whatever you prefer.
Usually the audience are a little shy, so I always ask.
Okay, and we have another question here, so
excellent.
you're joined.
So maybe this time I didn't have to. One aspect of implementation success relates to policy and politics. And very frequently, competing funding will prioritize programs that are seen by policy makers and politicians as adding to their career success and their visibility. I think sustainability, as you mentioned it, is very much influenced by funding. And I wanted to know a little bit more about your evaluation of the policy and politics component.
Yeah, well, that's not the kind of work that I do, but some of my best friends are policy implementation and dissemination researchers. Ross Brownson and Doug Luke, who are two of my closest colleagues at Washington University. Ross really has worked on cancer policy. A lot of his work has been funded by the CDC. And he focuses on dissemination research and has really advanced our thinking around how do we measure outcomes in dissemination, audience segmentation, audience reach, different methods. He's tested whether narrative or data is most influential with policymakers. Doug Luke, who leads the System Science Training Institute, works at the state tobacco control level. And so his research is with states and is doing policy research related to tobacco control. One of our IRI alums, Jonathan Pirtle, is at Drexel, and he does research on legislators and legislative aids. And he's been looking at what evidence do they accept, particularly in the area of mental health. And guess what? You know, they when we say mental health, immediately they think violent offenders. And, you know, that's counter to the evidence. So he's looking at, you know, what evidence, it's a lot of dissemination research, but he's also looking at their willingness to support legislation around the implementation. I would characterize this as an area sorely needing greater investment of projects, talents, and expertise. There's a little bit written, but this is wide open in spite of the fact that, as you say, we know that a lot of action is at the policy level. And we see this in global research, where it's, you know, a lot of implementation is driven top down. I've worked in countries where, you know, people were talking about how difficult it was to implement this, and the physicians hate it, the patients hate it, the nurses hate it, the social workers hate it. I tried to think of a tactful way to say, whose idea was this? And the idea came from on high. It was an order. And so we sorely need to better understand it.
So you talked about the fact that you don't get many applications for dissemination aspect of D&I, and I was wondering if you could elaborate a little more on what...
Yeah, we're not... people on this side of the room aren't hearing you.
Is it working now? Working now?
Much better, yes.
So you mentioned that you don't get many applications for dissemination research, and I was wondering if you could elaborate a little more on what sort of research projects would fall into that category. And especially I find the education piece sort of confusing, and a lot of the examples you gave of education fell more into the implementation, whereas I was thinking education could also be dissemination.
Okay, that's a really good catch. Yeah, so the question is, what are some areas where dissemination research could be important, where we need more of it?
Yeah, some examples.
Some examples, okay, yeah. Well, one area where there is some dissemination research going on pertains to vaccine acceptability. And there have been, for instance, some even experimental studies drawing on health communication research. So consider two scenarios, and these were actually tested in a study, where the provider says to a parent, well, it's time for your child's HPV vaccine. How do you feel about that vaccine? So that's one condition. The other condition was, it's time for your child's HPV vaccine, so the nurse will be bringing it in. And those two different dissemination strategies, you know, one is, if you will, patient decision-making and not exerting any authority, physician authority. You know, we don't do that with polio or measles, mumps, rubella, other vaccines. We don't say, well, how do you feel? Do you want your kid to get this? I mean, some providers may. And then another example of dissemination research that we've seen in a pediatric network in St. Louis is they tested the strategy of saying, my practice won't see patients who don't receive recommended vaccines. So it's time to get those vaccines. We're going to give those vaccines, and if the parent says no or pushes, says no, you can't, they'll say you need to find another provider. So those are different strategies for disseminating. It's time, it is the regularly scheduled time when this vaccine, that's the evidence. At age 12, you need this vaccine. At age 6, you need this vaccine. So we're giving parents that information that is evident in different ways, and we're testing that comparison. Another example is disseminating research about the effectiveness of mammography. And our health communications lab did some research where they either gave women, actually, a better example is that same group's research on colon cancer screening. And they tested 2 dissemination strategies with Black communities. In one condition, they said Blacks have a higher rate of death with colon cancer. They emphasized risk, and they were communicating data about risk. In another condition, they communicated information. Testing rates have rapidly increased among Black communities. And there are a number of sites that are those 2 communication strategies about evidence about colon cancer screening. So that's an experiment. Ross Brownson has done some experiments with legislators saying, do they want stories or do they want data of the same information? So those are examples of dissemination research that really lend themselves to experimental conditions. We need so much more of that. Because, health providers are out there communicating without a lot of evidence-based guidance. Okay.
Dr. Proctor, first, thank you for your talk. And second, thank you for the history of your work. I actually used your framework in a Fulbright-funded study I did in Rio this past year.
It got funded? Good for you.
I actually spent
the better.
It did, and so thank you. And the question comes from both the experience there in Rio, trying to implement alcohol-based Espert in primary care clinics in Rio, and work that I'd done across community health centers in New York State. And it's this tension between implementation of alcohol screening and brief intervention and the limits of our systems in terms of the way we've structured them. So whether it's on the medical side, the limit of capacity related to reimbursement that allows you 10 minutes per patient, or as you know, well know, the substance abuse treatment side, which is fractured at best. And so could you speak a little bit about how far implementation can take us given how broken some of our systems are and their structural underpinnings?
Other than just throwing up our hands and bemoaning the kind of the baked-in limitations that we know our systems have. My tried and true answer, because I'm both an optimist and a researcher, is we need evidence to show. We need to demonstrate the costs of limited infrastructure. And it's not a perfect example, but I always think of and admire the program of research on nursing. You remember the storyline that came out of that says nursing staff ratios save lives. Inherently, nursing ratios, staff ratios per patient is an infrastructure issue. It's, do we equip our systems with the kind of providers and expertise that are needed to deliver care? And, they embarked on a really ambitious research agenda, and they found that reducing staff hours of RNs increased mortality rate. Now, most of us are so busy delivering services that are trying to get them implemented that we don't step back and provide data on the counterfactual of, what would happen if we didn't. But, I think it's not sufficient, but I think evidence about the negative effects of infrastructure limits, that information is important.
We have one from Natasha Perez. What are the biggest challenges to implementation research?
Biggest challenges? For one thing, I think feeling like, and I probably accentuated it, that there are so many variables, so many constructs, that it's overwhelming. That, you know, it's how do I get started with this? To that, I counter, you know, don't try to put your whole program of research in every study. Knowledge is sequential, so let's start with doable, feasible research questions. And then finding collaborators. You know, our workforce is not adequately trained. We have 6 slots per year in the NIMH portion of our implementation research. 2 slots are funded by NIDA. 2 slots are funded by the VA. And we're the only training program in behavioral health. So, you know, the training doesn't have penetration, doesn't have reach. And third, it's multidisciplinary. It really requires teamwork. I think, you know, I had read a lot about team science, but I can't do implementation research without team science. So rather than go on and on about the biggest challenges, I'll talk about how to address them. Make a project doable. Partner with a trained implementation researcher and bring the necessary disciplines to bear. So you alone don't have to have all the expertise. You just have to know how to bring a team to bear on it. Thank you. I think we have one last question.
I do. Okay, so, well, it's kind of 2, but one is short and clarification. Did you say that 97% of mental health care is not evidence-based?
That's the results of a study reported by Kimberly Hoagwood, where they looked at states, and there's some measurement explanations of that. They looked at states where, although actually other studies are finding that only about 50% are, but in the Hoagwood study, they looked at states that said, we have adopted this evidence-based intervention. And then they looked at the data provided to see how many people were receiving, how many people got those services. And they put that over the denominator of people with identified mental illness, and that's what they came up with. Now, reporting could be, you know, maybe they didn't record all that was, but, you know, that's why records matter. So take a look at that Hoagwood study. It's really, you know, disturbing that, yeah, we say we're doing it, but the records show.
Some of that is explained by a lack of access to any services, and then the rest is explained by the lack of evidence for the services that are provided. Got it. Okay, so the thematic question, though, is like, so when we're talking about this kind of a consulting framework, I'm wondering if there are, so under the ACA, there was a lot of incentives for consolidation of healthcare providers, you know, like mega clinics, kind of. And so, and then there's some resistance to that among physicians. So I'm just wondering if, like, the way that implementation science is practiced conflicts with physician autonomy, or if there's like some difference between that and the way that like communities of content experts develop and certify their practices for them, like themselves. Or I guess that is maybe a portion of the methodology of implementation science. But is there a tension there?
You know, I think since guidelines were developed, there's been a tension, not only between physicians and evidence-based practice, but all providers. I'm in a field that used to characterize itself as an art. You know, there's the art of therapeutic interaction. You know, we've replaced that with evidence. But there, no doubt, are some people who feel that if there are recommended treatments or certainly pop-ups in a medical record saying do this, or there are guidelines, and you know, we used to have professional review organizations, pros, that did provider profiling on, you know, are your patients getting recommended levels of X, Y, and Z. So that did engender some pushback. I'm seeing less of that in newly trained health workforce. I'm seeing an eagerness to not only deliver new and demonstrated effective, but to figure out, how do I keep current? How do I keep bringing in new practices? Now, there's a whole body of research around how we can reduce that resistance, such as, now pop-up reminders, instead of saying flag, this is bad care, it says, oh, your patient would be eligible for X, Y, and Z. Would you please enter the reason they're not getting it? Well, that may still be irritating, but it gives room for people to say, no, I don't need to deliver the care as recommended. So, yeah, there's tension there. I think, at least in the circles I work with now, I see less of it than I did 15, 20 years ago.
Thank you. 2 days with us. It's been a privilege, and we've had a great time.
Thank you.
And I'll share the resources that Enola referenced in our newsletter.